Dr. Ham, Dr. Green was just finished up a trach and he's headed upstairs to his office. So I'll give him just one more minute. That's okay with you.
Yep, that works for me.
Oh, and there he is. So I'm going to stop sharing, Dr. Ham, and I'll let you share your screen, and Dr. Green will get us started.
Hey, can you hear me, Scott?
Yes, can hear you, and I can see Dr. Ham's screen.
Great. Oh man, you can see me too. That's not cool. Great. Thanks everybody for joining us. Sorry, I was a little on the run there, but that doesn't matter. Really happy to have Dr. Kendra Ham with us today. She serves a unique role. In fact, a lot of us probably didn't know it existed, but she's trained and double boarded in both pediatrics as well as pediatric abuse or child abuse. And so she's going to talk to us about a very important topic about recognizing this and recognizing things that may or may not be that. So I don't want to belabor that. Dr. Ham, I'm going to turn it over to you. Thank you so much for being with us, and we look forward to your talk for sure. Thanks.
And thanks for having me. Hopefully you can still hear me okay.
Yeah, we can hear you and we can see your slides.
Okay, great. I'm hoping that this will be somewhat interactive. I was hoping I could also see the chat, but I'm using someone else's computer, so that might be a little bit difficult. So Scott, I might actually ask you to help read out any responses in case people put responses in the chat. But welcome to Mimics of Abusive Head Trauma, or sorry, Abusive Trauma, not just Abusive Head Trauma. But I am Kendra Ham. I'm the medical director for the child protection team here with Atrium. Happy to be here today. I'm always excited to give you guys a presentation on things that I see every day. So we've got several objectives. Basically just want to explore some conditions that might be confused with various types of abuse, whether it be physical abuse, neglect, sexual abuse. And hopefully at the end of this, you'll understand that there are many conditions that can mimic different types of maltreatment. I'll have various case examples and types of mimics that you'll learn from today. I also want to reinforce the possible need for comprehensive evaluation when there is suspected abuse, and even knowing that there might be something that is a mimic, you might still need to do the full workup to figure it out. And then also, we want to understand at the end of this that just because a child has a medical diagnosis that explains the findings that they have, they might still be a victim of abuse. I have no disclosures as usual. Now, I know everybody on this in the audience today has seen a lot of different things, the big, bad, ugly, hence the need for the trauma conferences and symposiums. There might be something that triggers you today, and I encourage you to just divert your eyes away from the screen in case there's something that bothers you, but hopefully you can come back with us. All right, so why should we talk about mimics? We really need to know about mimics because we never want to overcall abuse or neglect. We never want to call Child Protective Services or DSS, as we call them in North Carolina, or even law enforcement if they're not needed, because they are very busy taking care of lots of different patients with various different cases. So we don't want to overwork them unnecessarily and then have families have to go through these experiences unnecessarily. But there are basically three types of mimics. So there are mimics that can look like an injury that's not actually due to trauma. There are injuries that can look worse based on a child's medical condition. And then there are injuries that have concerning characteristics that can look like abuse, but might be reasonably explained by an actual accident or non-abusive trauma. So we'll start with this first case, is the case of the easy bruisey, beautiful cover girl. Now, everybody should recognize what this is. And hopefully, if you don't, you'll know what this is at the end of our talk today and be able to recognize this in our patients. But this is an 11-month-old female that was reported to DSS due to bruising that the daycare noted on exam when they were removing her diaper for her diaper change. It was a brand new daycare provider that had never taken care of this patient before and got really upset because she saw all these bruises on this child's body. So any ideas what this could be? There should be lots of you that recognize this. I'm sorry, I can't see the chat.
Is it Mongolian?
That's correct. So
Ooh.
congenital dermal melanocytosis is the diagnosis, formerly known as Mongolian spots. Mongolian spots is not really a PC term, so we've moved away from calling it that, but you will probably have most caregivers, most parents recognize what this is, especially their kid has these spots on their body. So you might still have a lot of people that come in and call them that. But we do now call them congenital dermal melanocytosis, or you can hear some people call them slate gray nevi or slate gray patches. The important part about this is they are seen from birth, so they shouldn't just develop, over the course of a child's life. But they can resolve completely or even fade by the time a child starts school. So usually around the age of 5, when they start kindergarten, you can see that these spots have faded pretty significantly. They're not painful, not irritated, but they are very frequently confused with bruises, especially with daycare workers, people that work in school, because they can look very similar to bruises. There are some races and ethnicities that more commonly have these, including African American patients or Black patients, Asian, Latinx, Native American patients, but you can see this in any race or ethnicity. They're very commonly seen on the back, shoulders, buttocks, but they occur anywhere on the body, including on the scalp. So it's really important to recognize what these are. It's also truly important because I've had several cases of kids that have been referred to our child advocacy centers, and they've already called DSS. DSS has already had these safety plans made. They're already saying that the parents are abusing the kids and going to possibly take them from their care. And it's actually just birthmarks. So it's really helpful when kids are even in the nursery setting. If you can document that in well visits in the nursery and the ED, if you're doing surgery and no one's ever documented it before, it can be incredibly helpful. Because I've seen cases where DSS has gone through the medical record and they said, well, no one documented them before. How do we know they're bruises? And we're almost having to argue with them and say, like, these are actually just birthmarks. So it's really helpful to document when you see them, regardless of why the patient's coming in, and then also make note of all the different areas that you see them. Now, here is an example of a kid that has congenital dermal melanocytosis, but they also have, you see these linear bruises going across their back, sacrum and buttocks. So this is a kid that had congenital dermal melanocytosis, but also had physical abuse at the same time. So just kind of beware. Again, they can have a mimic of abuse, but also be abused. This is our next case, the case of the 2 thumbs down, and you'll see why I called it 2 thumbs down, because this person is performing a genital exam. You can see their thumbs, they're not wearing gloves. Highly discourage that. Always wear gloves when you're doing this type of exam. But this is a 6-year-old female that came into the ED with concern for possible sexual abuse. She was reported to have had some watery vaginal discharge for about a day. Really no other symptoms other than just itching. Didn't have any painful urination. And when you talk to the child in a child-friendly way, she denies anyone touching her inappropriately or any other disclosure of abuse. Any ideas what this could be? You see this yellowish substance. What we're looking at here, you can't really see all the anatomy, but this is the top of her labia minora here. Clitoral hood would be up here. And then this is the hymen, which we typically will focus on when we're evaluating for sexual abuse. And you can kind of see in the vaginal cavity. Any ideas? Anyone? Anyone? Bueller?
Nothing in the chat box.
Oh, sorry, my speaker was really staticky there. What'd you say?
There's nothing in the chat box.
I'm so sorry. It's so weird. I can't hear.
Oh, we have a rectovaginal fistula, and I'll probably say it wrong. Candida infection.
Okay, I hear you saying fistula. For some reason, my speaker is really staticky in here. It's the problem with using someone else's computer. That's a really good thought, though. This was actually a thumbtack that she had inserted herself. and was able to actually give that history. So I on purpose didn't tell you the full history just to see if you came up with that, but I like the fistula response. That's actually really good. But so foreign bodies can happen, especially with prepubertal girls. They not often will even have vaginal discharge, but they might come in with vaginal discharge. Usually retained toilet paper is going to be the most common finding that you'll have. They can come in with vaginal bleeding. The child, if verbal enough, may actually tell you what they've done. And just like we see kids that come in with foreign bodies in their nose, their ears, they can actually put things in that part of the body as well. It can be associated with sexual abuse, but oftentimes what happens is these kids are just found out that they have an opening in the area too, and they insert an object, but we still have to go through the whole process just to make sure that there's nothing else going on. All right, next up we have the case of the baby jowls. So this was a sweet little 4-month-old female that was born at 35 weeks. She just spent a week in the NICU, just feeding and growing and helping with her respiratory support. She came into the ED for reported arm swelling that had been going on for about a day. Mom said the day before she had noticed that her right forearm was swollen. She denied any trauma. No falls were reported. Mom thought originally that she had just been bitten by a mosquito. And then Mom said that she herself had multiple mosquito bites, but she didn't actually see a mosquito bite on the baby. She said the day before she wasn't acting like she was in any pain. She was just acting like her normal sleepy self. And then the patient was supposedly moving her arm appropriately prior to coming to the ED, didn't seem to be in any pain, but once she was in the ED, appeared to be in pain, was reported to have decreased oral intake. And you see on the skull film that I have here, she had some abnormal expansion of her mandible. Well, then the ED goes on to do some additional imaging, looking first at her right forearm, and you see this mild periosteal reaction to the radius, but then you also see pretty exuberant reaction on the ulna as well. I'm like, oh, that's really strange. They look at the left forearm and you kind of see some medical equipment in the way of the x-ray, but you see it on that arm as well, and then also the tibia. Eventually, they get the full skeletal survey because they're really concerned for this periosteal reaction. Now, I have a normal chest x-ray here on the right side, and then here's her chest x-ray on the left. You see this exuberant periosteal reaction covering every single one of her ribs. Every single one. Not one is missing. But what you should note is there have been no fractures up to this point. So pretty much every bone in her body had this periosteal reaction. Any ideas for the diagnosis? I'm going to see possibly if you can put it in the chat. I should be able to pull it up here. Happy disease, Dr. Barrett, you're cheating. But you're correct. All right, so Caffey disease, very rare, but it does happen. This is only the second patient I've ever seen with this disorder, and I've been seeing these patients exclusively since 2013, so that says a lot. But Caffey disease is also called infantile cortical hyperostosis. I feel like sometimes it's easier to remember things not by the name of the person that discovered it, but instead the actual name. So infantile cortical hyperostosis tells you that it affects infants and involves cortical thickening on multiple bones, where they do have this painful subperiosteal new bone formation. Usually kids are going to be diagnosed in the first 6 months of life. So our patient was 4 months, so she was in that age range. And one of the hallmarks of this disorder is that the mandible is involved in the majority of the cases. So most of the cases will have mandibular involvement. And the clavicle and ulna are also very commonly affected, but any bone can be involved. And one thing I've wondered and have never gotten an answer to is, I wonder if even the ossicles in the ear could be involved too, since they say any bone could be involved. But it involves the mutation in the COLIA1 gene. And if you remember genetics, the choline-1 gene is implicated in osteogenesis imperfecta, Ehlers-Danlos, and other disorders that affect collagen. It can be inherited. This patient, there was no family history of that. One thing to note is that there are no associated fractures. They never have metaphyseal irregularities as a result of this disorder itself. So if you see fractures, if you see metaphyseal irregularities, start also thinking about abuse as well. Treatment for this disorder is typically just supportive care for pain and fever. Ortho absolutely needs to be involved because they need to follow these kids long-term to make sure they don't have those long-term sequelae or complications. And one of those can be fusion of various bones. And you can think of, the difficulties they might have if their bones are fusing together. And then they can also have variability in limb length. It typically resolves by the age of 2 years, and most of the time these children do really well, but they do have to be followed for this. All right, here's our next case. Let sleeping babies lie, and we'll find out why. So this was a 3-day-old male that presented to the ED after falling asleep. Mom falls asleep, breastfeeding him. He falls to the floor. So of course, dad's asleep the whole time because that's a lot of time what dads do when moms are up. Just kidding. But mom was breastfeeding and she totally fell asleep and didn't realize he hit the floor till she heard a thud. She thought the bed was maybe a little less than 3 feet. So he fell less than 3 feet to a carpeted floor. She woke up, turned on the lights, and saw that he was lying on his right side. He was sleeping, and he only cried when she picked him up. So he didn't even cry when he hit the floor. She denied any loss of consciousness, said he didn't have any vomiting. Birth history was uncomplicated, didn't have any issues. And then based on PCARM criteria, he probably didn't need a head CT, but the ED did order a head CT. And then they got this. You see on the left of my screen here, he didn't have intracranial hemorrhage, but he was found to have horizontal acute occipital skull fractures on both sides. It's like, short fall. He didn't even cry. He doesn't have any scalp swelling, not to say that you have to have scalp swelling with a skull fracture. But they move on to admit him for a non-accidental trauma workup. Got the trauma screening labs that were unremarkable. The only thing of note was that he had an elevated total bilirubin, but it was still under the threshold for phototherapy. And at the age of 3 days old, we're pretty used to that. And they requested for me to do a consult. And I said, that's fine. But when I'm looking at the head CT, I said, I'm not really convinced that these are skull fractures. So I then requested a 3D reconstruction and told the team to hold off on the rest of the workup. So here is the 3D reconstruction. And you can see that he's got this pretty symmetric lucencies in the occipital bone here. I mean, it's almost too perfect for a skull fracture. Any ideas what that could be? Pull up the chat again here. Dr. Ross is 0-2. Someone says birth trauma, forceps. So they actually said that there was no birth trauma. They didn't use forceps or vacuum or anything, but that's a really good thought. Any other thoughts? Incomplete closure of the skull sutures, yes. Congenital non-fusion, awesome. All right, so essentially what we have here is a Mendoza suture, so accessory sutures. And typically we don't even know about these until we get our head imaging. And then we say, that looks like a skull fracture, but it's very helpful to get 3D reconstructions in these cases because you could almost see it better on the 3D reconstruction, just how perfect. It was almost too perfect to be a skull fracture. Normally they have more jagged edges and things like that. And it was just too perfect. And I thankfully had neuroradiology agree with me. And then we were able to save this family from any further workup and DSS being in their lives. So this is well documented in the literature, where Mendoza sutures specifically are found in the occipital bone, and it occurs with a defect in the ossification process. We don't really know the true prevalence because we're not just head imaging all these kids that come in for various complaints. But like I said, a 3D reconstruction can be very helpful, and it's documented in the literature that we probably should be asking for this every time, which is something that I've tried to work on here. I haven't really been successful, but I'm not giving up on that. So if we compare that to actual skull fractures, we have kids under 2, that's actually the most common fracture that they'll have. When you think about kids, they just tend to have these really big heads, for lack of better terms, right? They have big heads. When they fall down, the head is typically the first thing that's going to hit the floor. So that's why they end up having lots of skull fractures, usually in the parietal skull region. The prevalence of skull fractures and abuse is actually not that high. It's around 10 to 13%. So when we have these kids coming in with skull fractures and we're doing these NAT workups, most of the time it's going to be an accident. Not to say you shouldn't work it up, but that's typically what it's going to be. And these can occur with accidental falls, usually from moderate heights, around 3 to 6 feet. So when they say they fell off a kitchen counter or even the coffee table, they could totally still get a skull fracture from that kind of fall. There is a low incidence of skull fractures or serious head injury from the bed or couch falls. And then complex skull fractures are typically associated with higher falls just because of the amount of forces that are generated. And complex skull fractures meaning those that cross suture lines or involving multiple different bones in the skull. So awesome, good job with that. Next case is the case of the red bottom, not to be confused with Louboutin shoes. And if anybody's in Starbucks or Panera, please make sure there's nobody looking at your screen, by the way, because they might be calling somebody on you because it might seem a little inappropriate. So we've got a 6-month-old female that presented with redness and peeling on her skin, on her buttocks and vaginal area or vulvar area, was brought to the ED. Again, this person not wearing gloves, huge pet peeve of mine. ED calls DSS because they're worried about an unexplained burn. And then on review of systems, the parent stated that she had just been experiencing some constipation lately, but otherwise had been fine, not really fussy or anything like that. All right, let's see what you guys think. Any ideas? What could be causing this redness, peeling? You can also kind of see like this blister formation. I see strep, that's a good thought. Any other ideas? The hint is that she's been experiencing constipation. Yeast and allergy are also really good thoughts too. All right, well, it's actually due to ingestion of laxatives. So we typically do not recommend for parents or caregivers to give their kids laxatives to treat constipation. But senna, when it's in a laxative and it comes out the other end, it can be really irritating. It can cause this crazy rash. It can cause blisters and skin sloughing, and it can be pretty severe. And so that's why we don't recommend for babies to have this. And that's what the parents had done because great grandma had told them, oh, you should just give her this and it'll help with her constipation. But it can look like a scald burn. And how this is different from a scald burn or immersion burns, you see this kid on the other side of the screen here that was immersed in scalding hot water. And you see that there are these areas of sparing. So typically in immersion burns or abusive burns, kids will squeeze their buttocks, they'll flex at the knee, they'll flex at the hip, and so they'll have these areas of sparing. And then you also see this one here on the left buttock because once the kid hit the bottom of the tub is actually cooler than the scalding hot water around it, so that area was spared too. I like the thoughts. I love the differential that you guys are coming up with. All right, our next case is the case of the owie, which will probably make a few of you guys queasy. But this was, I don't have a picture up yet, but this is a 6-year-old girl that presented after a minor accidental trauma. She denied any inappropriate contact, but is babysat by mom's boyfriend, and everybody's intending to go up when we hear about mom having a boyfriend, but it's not always mom's boyfriend, just FYI. She was playing outside. He wasn't watching her. She yelled owie, and then he ends up calling mom because the child had blood in her underwear. So thankfully, we actually had a picture of this patient. Oh, look, someone's wearing gloves when they're doing this exam. Wonderful. We had pictures of what she looked like before her injury occurred. And so we're able to compare that to what she looked like when she came into the ED. This is what she looks like. So these are her labia minora. You can barely see hymen. Not sure if that's hymen or urethra behind here. It's really hard to tell because of the anatomy. You can't see her labia majora because the person is applying traction to that area to be able to see. So then when she comes in, this is what she looks like now. So clearly very different exam compared to what was seen before when she was just seen for a well check. So what do we think here? Sorry, Scott, I just saw that your home remedy for a constipation, that was good. Someone says bike, hymen rupture. That's what we've got. So these are abnormal skin bridge, congenital malformation broke. Yep. Very good. So these are actually labial adhesions. Let me pull up my other screen here. So you can see that the labia minora here is basically fused together. You see this opening here, but you really can't see all the anatomy behind it. And she was riding her bike and she fell and actually lysed this area on her own, which is why she had bleeding from that. Very good. So typically labial adhesions are asymptomatic incidental findings. But what I'm learning more and more is that we're not doing a very good job of teaching and educating our residents and other providers to look for this when they're doing their well child visits. The incidence is pretty low, around 0.6 or 3% in prepubertal girls, but we know that some PCPs never look. They really just look to see if there's pubic hair, and that's it. But they are typically caused possibly due to just local irritation combined with low estrogen. You don't typically see these once girls hit puberty. They can be lysed just during normal play or minor genital trauma. Treatment is usually short-term estrogen. You have to be really careful with that and not use it too long. You can use steroid creams. Once they do lyse on their own, we typically will recommend for them to use emollients, even just Vaseline, to keep the tissues from re-adhering together. You can also perform surgical separation. Do not just try to do this in your office. Don't just try to do it in the ED. It needs to be under a controlled setting. This can mimic sexual abuse because it could occur during sexual abuse. You'd also want to consider female genital mutilation as a cause of them as well. So awesome. All right, our next case is the case of the dip your toes. This was an 8-month-old male that was brought in with a blister on his toe. PCP called DSS because really worried about this being a burn. If you think about it, think about how you would burn just the toe is the other thing. So baby doesn't like wearing socks or shoes, according to the parents. There's absolutely no story. Sometimes that happens. They come in with no story, and then we get all worried because there is no story and it looks like a burn. But parents said they just took his socks off and noticed this, and that was it. Any ideas what that could be? Feline? I've always said it wrong. Felon, feline. Any other ideas? Infected foreign body. That's a very good thought. Pins. Oh yeah, that's a good thought too. Y'all are getting pretty close here. Is it a true blister, toe sucker? Child sucking on toe? It's a good thought. They had never seen this baby sucking on his own toe. But that's a really good thought. This is blistering distal dactylitis. I haven't seen this in a really long time, but it can happen. It's typically caused by Staph aureus. If it's caused by staph, you'll usually see multiple lesions. or it can be caused by group A beta hemolytic strep infection. So it's really just a superficial blistering lesion over the end portion. It can happen on the finger or toe or palm or sole. And it really does look so similar to a thermal or flame injury, which is why that PCP was really concerned about it. Usually non-tender treatment, you want to do incision and drainage to see what grows out, do a culture, so you treat the infection. Awesome. Next ones are, these three are bewildering to me. All right, let's see if you guys know what this first one is. On the left here. Cupping. Nice work, Dr. Evans. And lots of people saying cupping. Very good. What about this one in the middle? Points. Yes. Awesome job, Angela Swift. I don't think I've met you before. All right, what about over here on the right? This one tends to trip people up. It's not cigarettes, I can tell you that. It's a mimic. I figured that one would trip you guys up. Okay, so that one is moxibustion. We're going to go over all three. These are all cultural or holistic remedies that people can use to treat various ailments. So we'll start with cupping. I think Michael Phelps made this really popular or made us more aware back when he was in the Olympics and swimming, and he had these lesions all over his body. And people were saying, what in the world is going on here? But this is a remedy that's used really frequently in Asia, Russia, Mexico, and it helps to relieve fever, pain, abscesses, and congestion. I think he used it to help relieve his muscle soreness from all the training that he had to do for the Olympics. It's believed to increase circulation and release bad toxins. So what happens is these cups are heated and they create a vacuum on the skin, almost kind of like a hickey. And then that is placed on the skin, and you can see the skin going up into the cup. It looks like it's really painful, but people who have told me they've had it done say it's actually not really that bad. And then you've got coining and spooning is frequently seen in Southeast Asia. So this is also performed to help improve circulation. I've seen this actually in a child that had asthma exacerbation, and his grandfather was visiting from Vietnam. And he tried coining to see if it would help, and they ended up coming to the ED, and everybody got really weirded out because they saw these lesions on his back, but they came in with a story. So coining, you first rub the area with this medicated oil, and a coin is used to brush across the skin surface in a symmetrical pattern. Same thing with spooning. And the lesions generally last about 1 or 2 weeks. They shouldn't leave long-lasting injuries or scarring, but you might still have some hyperpigmentation after it. But usually people are fine after they have this done if it's been done correctly. Now, moxibustion, also used in Southeast Asia, is using this moxa stick, which looks very similar to a cigar or a cigarette. And just of note, there are some acupuncturists in Charlotte that say that they will do all these various remedies. So just keep in mind, you might see a patient that comes in with these lesions. But essentially, they just use this burning moxa stick and they apply it to the skin in various patterns to help relieve various ailments. So it really can look like a cigarette burn, but again, they should be able to come in and tell you this story. They can't just say they don't know. All right, case extra tequila in my margarita. All right, we've got a 3-year-old female that was on vacation with her family in Cancun. So they came back a little bit early because she developed these blisters. They didn't want to go to the hospital in Cancun. They'd rather come back and see their PCP. When they come home, this is what her hand looks like. So there was a little bit of delay in care because they had to rearrange their travel. These blisters had developed on her hand about 2 days prior. So you see these blisters here. She's otherwise okay, not having fevers. The only story is that they are, drinking margaritas at the pool, having a good old time, and child develops these blisters. Ah, nice. So we've got citrus, fruit, and sunshine. That's awesome. Citrus and sun. Very good. Leeches, I'm not sure if that was from before or after. Okay. Very good. So this is phytophotodermatitis, also called margarita photodermatitis, not to be confused with Lyme disease. It's Lyme instead of Lyme, or Bordeaux dermatitis. So it's this photosensitivity reaction that results from coming in contact with certain plants. And these plant oils or sorolins are then, when they're exposed to sunlight, it causes this reaction. So kids can come in with swelling and blisters. In really severe cases, they can have scarring. But here are the common culprits at the bottom of the screen here. Celery, limes are probably the most common that I've seen. The hint there was that they're making margaritas or drinking margaritas. And what she was doing is that she was taking the limes from their margaritas and then squeezing them in her hand. So then she had the juices all over her hand and she was standing out in the sun, causing that reaction. So awesome job with that. Next case is, I was going to sing this, but I decided not to. Summer, Summer, Summertime is a song by Will Smith. I will refrain from singing during this presentation today. So we've got a 2-year-old male who presents with a funny shaped mark on his chest. We're in North Carolina. It's 90 degrees. It's maybe even 100 degrees because it tends to be pretty hot here in summertime. He doesn't like to wear shirts. He prefers just to be in his diaper. Mom said she put him in the car and he's screaming the whole way home. Any ideas what caused this? Oh, I just saw Dr. Ross's comment, vampirism. Heat rash, car seat burn. Oh, yes. Very good. It's a car seat burn. All right. So you can see the pattern here on his chest. The thing to notice is not just the metal part of buckles and car seats that can cause issues, but the plastic too. The plastic can get really hot. And, you know, when your car seat or your car is sitting out in the sun and you put your kid in there and they're not wearing a shirt that might have protected them from this burn, it can happen that way. Because it really does get hot inside the cars here in the summertime. And the straps tend to fit pretty snugly to help protect the child in the car seat. They're not supposed to be able to get out of it on their own. And so he's screaming the whole way because it's hurting so bad. Skin is burning because he can't get out of it. Oh, we are moving right along here. So we've got case of the hives. This is a 2-year-old female that came in with really weird shapes all over her legs. The only history is that she was recently diagnosed with an ear infection a few days ago and started a new medication. Any ideas what the diagnosis might be? Thinking about how you antibiotic reaction. Any ideas what you would specifically call that, sorry. And sorry if you can hear the helicopter above the hospital right now. Penicillin allergy, very good. What would you call the actual findings on her skin? SJS, very good thought. Cellulitis is also a really good thought. We typically see target lesions in this. You can kind of see they look like almost like target lesions. Some of these kind of look like horseshoes, maybe a little coalesced here. Okay, it's erythema multiforme. Don't ever forget about this one. It tends to cause these red lesions or target lesions. Can be caused by various viruses and definitely medications. So I love that you guys came up with the penicillin reaction as well. Sulfa drugs can do this too. It's self-limited. The treatment is just to remove the inciting agent. So I can see how someone would think like, oh, these are loop marks on her or loop bruises, but no, just erythema multiforme. All right, we've got a case of a too hot in the kitchen. We've got a 2-year-old female with burns to her back and left side of her face and ear. You can kind of see a little bit on her face, left ear, and then this burn going all the way down her back here. Mom said she was cooking. She ran to check her phone. You know, she's got to check her Instagram. Came back and saw that the child was screaming. The injury was totally unwitnessed because mom was on her phone. Any ideas? This is not really a trick question. Cold hot water on top of her. Absolutely correct. So I think some people get a little worried because they see it on the back of her body. So on her back, yes, scald burn. Yep. So what happens is with accidental burns, kids can pull the hot liquids from stove surfaces. If you've got coffee on your coffee table, they tend to want to mimic what we're doing and they want to try to cook. They want to drink whatever you're drinking. And so what they end up doing is they pull it on themselves. So it can hit their faces, it can hit their ears, the tops of their bodies, their chest and abdomen, but they can also pour something or knock into something, causing a burn to their backs as well. And so you see with her, or in this picture here, you can see that this kid is, pulling on something and then the hot water hits his face, his ears, the top of his body first, but it tends to get a little less severe as you move towards the lower part of the body. So it's going to be more significant at the top compared to the lower part. As the liquid flows down as it becomes cooler. Awesome. Here's my case of the not it. This one is a doozy. Not gonna lie. One of you or two of you might have actually seen this case with me, but this is an 8-month-old female that came in with indurated bruises. Absolutely no story whatsoever. No significant past medical history. The only concerning history is that mom had a history of drug abuse and all the social determinants of health are positive. So transportation, finances, all of it was positive. All right, so she was found on her labs to have new onset anemia, coagulopathy, with these multiple indurated bruises on exam. She also had transaminitis and jaundice. And toxicology got involved because they were worried about possible ingestion of Coumadin or other superwarfarin initially. And then they consult me as well. And I took one look at her and her labs and I said, not it, but I'll still help you, but also not it. I don't really think this is abuse, but I said we can still go through the workup just to make sure. But I don't think we're going to find anything from an abuse standpoint. And I recommended trauma screening labs and a bleeding workup. So coags get done and they are out of this world, significantly elevated, even when they are repeated. The only normal one was fibrinogen, so PT and PTT were significantly elevated. And then they got the factor levels. Now I'd recommended factors 8 and 9. Somehow 8 didn't get done until after she was transfused, but factors 2, 7, and 9 were basically non-existent. Her hemoglobin was also basically non-existent of 3.9. She had elevated AST and ALT, also concerning, high ammonia. Vitamin D level was 8, which is also extremely low. All right, so here are her photos. See these multiple bruises. This is on her back, on her side or torso. I mean, it almost looks like it's in the distribution of her ribs, but when you put your hand on her body, you can feel them. They're very indurated, very unusual bruising on her chest. Couldn't really explain that from abuse. Any ideas? I don't expect anybody to get this one because I also didn't know. Hepatitis is a very good thought. We just think about liver involvement, liver failure. Yes. Absolutely correct. Well, I stand corrected. You guys are smarter than me. I didn't know what was going on. I just said it was not me. So this is a physical abuse mimic. She had confirmed progressive familial intrahepatic cholestasis type 2 or PFIC type 2. So essentially her liver was failing. And the complication of this is liver failure within a few years of life, and they can later risk developing hepatocellular carcinoma. But it's essentially just this really rare inherited liver disorder that causes buildup of bile salts in the liver. And I think when people heard that mom had a history of drug abuse, they just assumed that she had given this child something. I think it was kind of bounced around that maybe she gave her rat poisoning. But, sometimes we get a history and it can kind of deter us from where we should be going. But we eventually came up with the right answer. I guess GI did. I didn't personally, but they found this out via liver biopsy, and she required vitamin K administration. You want to treat the cholestasis, which really helps their findings. She had to get fat soluble vitamins as a supplement. Surgery is also an option, especially if they are in liver failure. So, very good, guys. Now, I do have to mention other medical conditions that can predispose to bleeding and bruising, which is why I wanted to do that workup. So von Willebrand is the most common heritable bleeding disorder that we will see in our patient population. They can come in with bruising, nosebleeds, prolonged menses, not usually in our little patients. I'm not going to see like the prolonged menses, but they can have bleeding after dental procedures. And so you want to get your von Willebrand panel. There are some hospitals that offer a full panel. We usually have to request the antigen factor, multimer factor 8, and then also vitamin K deficiency. It can usually present in 3 different time frames, perinatally, within 24 hours of life. Classic presentation is within a week, like a day to 7 days. And then late presentation is after 2 weeks of life. Usually that's acquired through chronic liver disease, antibiotic use. And this is one of the reasons why they were worried about warfarin ingestion. But it can cause pretty significant hemorrhagic disease in the newborn. So just be mindful. There are a lot of people that are not wanting to do vaccines or not wanting to do vitamin K now, even in the nursery period. So just be aware that when kids come back with intracranial hemorrhage and bruising, if they've not received vitamin K, that might be the cause. Typically with vitamin K deficiency, you'll have prolonged PT and PTT, but a normal platelet count. And then also hemophilia A and B. We've definitely had some patients with this. I've definitely seen a patient that they forgot to get one of the factor levels, and it was that one factor level. If they had gotten it, they would have made the diagnosis sooner. And so kids can come in with bleeding in their joints, bleeding of the mucosa, intracranial hemorrhages, and muscle bleeding after just benign trauma. So factor 8 will be decreased in hemophilia A, and factor 9 will be decreased in hemophilia B. And they typically will have prolonged PTT. You can also have disorders of collagen like Ehlers-Danlos, vitamin C deficiency, idiopathic thrombocytic purpura. I actually saw a kid, they referred her immediately or urgently to our Child Advocacy Center. I was told from the ED that she had normal labs. She got to me and I looked at her exam. I said, I don't think this is abuse. And I looked at her platelets and she had 10,000 platelets after I had gotten the report that she had normal labs. So just make sure that you look at all the labs so that you can give appropriate report to the next person. Then there's also factor 13 deficiency, and our hematologists here tend to want to include that. It is incredibly rare, but you don't want to miss it at the same time. And so with factor 13 deficiency, presentation of intracranial hemorrhages is pretty common. The classic presentation, though, is that kids will have prolonged umbilical stump bleeding in the majority of the cases. So if you have a family member that comes in or a patient caregiver that comes in with that history, then really be thinking about factor 13 deficiency. They can actually have normal coags, which will make you think you don't need to do anything else, but just be aware of that. Most often it's diagnosed in infancy, though. I know that you can't see this algorithm very well, but I wanted to include this article that was published back in 2022. And it's an algorithm that shows if you have a kid that presents with just bruising, what you should do, what questions you should ask, if you should actually even do a bleeding disorder workup. Same thing for intracranial hemorrhage, and I'm happy to send this to Scott and he can distribute it to you guys, just so you have it with you. All right, I think this is our last one, and I'll have some time for questions. But this is the case of the bath time discoveries. So this was an 18-month-old male that when I was living in South Carolina, they had this state facility where moms could live there and go through their drug rehabilitation. with their child living with them. So they didn't have to be separated from their kid while they got drug rehab. Sounds like a great idea so that you don't have to separate families while they're getting the help that they need. However, this mom was giving this child a bath. One of the facility staff members walked in while she was giving the bath and said, "What is all this all over his back? What are those marks?" Mom said she didn't know where the marks came from. There was no witnessed injury. Any ideas what caused all these findings on this kid's back? And also you see one on his forearm here. Again, he's 18 months. The cat. Very good thought. Bite marks. Yes. Are we thinking human bite marks or animal bite marks? Yes. Bites from other children and other kids, small bite. Yes. Awesome. And as you can see, I included the measurement here, and we'll talk about that. So I ended up diagnosing supervisory neglect. So he came in, they started this whole NAT workup, and I said, "Stop, don't do anymore." So it turns out he was actually found in a room with multiple children under the age of 4 years. The state facility got in trouble because they weren't supervising, and this kid went through all these medical procedures, including imaging, and it could have been avoided. So I did measure this, and what you typically will want to do is measure the intercanine distance. Usually now, 2.5 centimeters to 3 centimeters is going to be a child bite versus 3 centimeters to 4.5 centimeters being an adult bite. Now, I wouldn't say like absolutely those are the exact measurements because there might be some variations there. But I had the pleasure of having a dentist also look at this with me and agreed with me that based on the size of the teeth and the way they looked, that was likely a child bite. So typically with animal bites, especially dog bites, they tend to tear the skin more so than when children bite each other. And you see this central ecchymosis in here. So the kid was biting and like sucking the skin up, almost kind of like that cupping picture that I showed you. But he did it multiple times, or she did it multiple times. And obviously this kid couldn't have done that himself, but it was really concerning that it happened so many times. It would have been painful and aggravating. And nobody was watching them. So awesome. Very good. Any, here are my references, and I'm happy to share those with Scott and he can distribute them out. But any questions? I had a couple more I could have done, but I wanted to see if you guys have questions. Yes, Scott. Hopefully I can understand you. The speaker is weird.
Can you hear me now?
Yes, I can.
So now that you've opened up this Pandora's box of it's not really abuse, how should we document this? Because our concern is that it's not documented, like you mentioned earlier in your presentation. And then later on, there's no documentation to create a pattern. So how should we document these findings? Just call it as we see it or what?
Exactly. Call it as you see it. You can also still put in your differential that you considered abuse and then just say why you didn't think it was. We're always happy to work through these cases with you as well. And whenever I talk to someone, I say, you feel free to put my name in. I'm not upset about that. If you want to say you spoke with Dr. Ham and she said blah, 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 it's totally fine to throw me under the bus in that way because we're talking about it anyway. So. Yes, Dr. Green.
Yeah, this is really informative and thanks very much for doing this for us. I have to note all of the wrong answers by surgeons on here, including myself, which I, at least is entertaining, but does show our lack of familiarity with a lot of this. Are we no longer supposed to be using the term non-accidental trauma? Is there something on the legal side that we all need to be informed about? Or is that a thing?
Yes, that's a really good question. And I would say specifically what you're concerned about. So if you're worried about physical abuse, worried about sexual abuse, worried about neglect, but say those specific terms instead of just non-accidental trauma. And the reason why in legalese, essentially when we go to court is like, well, dad accidentally slammed the baby or dad accidentally threw the baby across the room. It's like they try to say, well, that wasn't really on purpose. So they try to also like figure out if we're saying it's on purpose or not. No one is on purpose trying to hurt their kid, usually. But that's a really good question. I know we still use, do the NAT workup a lot in documentation, but when you see our our notes, you'll see us trying to say something more specific, like concern for physical abuse, concern for abusive head trauma, concern for neglect, concern for sexual abuse. I do see sometimes kids come in for concern for sexual abuse and people say admitted for NAT workup. But no, it really should be, admitted for sexual abuse workup. Yes, Scott.
A few of your slides reference kind of like a Eastern versus Western medicine. Could, other than just the not understanding different cultures, could any of those actually be abuse in our society versus other cultures?
It is possible. They should be able to come in and say like, hey, my kid had an asthma exacerbation. That's why I tried coining or spooning first. But I could see how any of these could turn into abuse for sure. So you just want to keep that. You can always put it in your differential in your note and say like, well, the story lines up with what the parent said. If the kid is verbal enough, they should be able to tell you as well. But yeah, I could see how any of this could be an abusive mechanism too. That's why we really rely on history. Any other questions? Don't see any in the chat.
No hands raised and no chat boxes.
Yep. Awesome. I really appreciate you guys allowing me to come back and talk to you again. Happy to come back again and talk about whatever you'd like me to. I think someone had actually mentioned me coming back and talking about neglect one day, which I'd be happy to do that too.
Great. Well, thank you very much. Been very informative. We appreciate your time and input. So thanks for being here. Unless we've got something else, we will adjourn. Thanks everybody for joining us.